The rollout of the highly touted Social Health Authority on the 1st of October was a culmination of a year of push and pull as the Ministry of Health made the transition, and most notably, it was also the realization of a campaign pledge by President William Ruto, who had championed universal health coverage in his manifesto. But as Mary Muoki now reports, the rollout, which was hit employers by Kenyans, had courtesy of a 2.75% deduction on gross salaries, has been nothing short of chaotic, from running into legal headwinds to locking out the very patients it was designed to serve. Stakeholders in the health sector have passed a unanimous vote: suspend the implementation until all the T's have been crossed and every I has been dotted.
The introduction of the Social Health Authority was intended as a beacon of hope for universal health coverage, but contrary to those expectations, it has sparked a maelstrom of discontent among patients, healthcare providers, and faith-based organizations. Its implementation has been marred by allegations of patient discrimination, financial mismanagement, and total operational chaos.
Nimeambiwa nilipe pesa. They need cash. NHIF is not going to work anymore. And the pension is 9,000. I need another 9,000 tomorrow, of which I don't have money right now. So, mimi nataka pesa, lakini pesa ndio sina.
Let them work on the SHA. Patients are suffering, and they have a right to be served.
Despite President William Ruto's constant defense of the increased premiums, which have particularly hit the employed hard and seen their payslips shrink further, it is imagined that hospitals are restricting access to SHA benefits to government employees, leaving many out of what was promised to be an inclusive health insurance system. A survey conducted by the Non-Communicable Disease Alliance of Kenya found that private hospitals, including Nairobi Hospital, Ruai Family Hospital, and specialty clinics, restricted shift coverage to civil servants in specific job groups, forcing non-civil servant members, despite their fully paid-up memberships, to make cash payments for services that would be covered under their SHA subscriptions.
Public hospitals such as Kenyatta National Hospital and Kenyatta University Referral Hospital reported frequent systemic delays that left patients waiting for hours, restricted shift coverage to civil servants in specific job groups, leaving most NCD patients ineligible. Cancer patients, transplant recipients, and other high-risk groups are especially affected by these limitations.
In the face of this blatant discrimination, patients across Kenya continue to suffer the consequences as some facilities refuse to treat SHA-covered individuals due to payment uncertainties. This has left many, especially those with chronic conditions such as cancer or diabetes, in a precarious position, unable to receive timely or any treatment at all.
Any interruption in treatment and care, as we have seen since SHA was rolled out, is likely to have a deleterious effect on the patients and the individuals living with different non-communicable diseases. Cancer is not waiting for us to sort out shift.
Seemingly, patients are not the only ones feeling disenfranchised by the rollout of SHA. Faith-based hospitals, which have long been integral to Kenya's healthcare landscape, have also been vocal in their struggles with SHA's rollout. These institutions argue that the government has not clearly explained how SHA is going to pay off the substantial debts owed by the defunct NHIF. This has put additional strain on the already tense implementation process.
We worry about a transition with claims pending is because also there is a system change. And we've had experience in the past when where a system changes and some of the claims that were on process kind of become lost in the system. And it takes time before you can have them reconstructed, audited, verified. We've been following up, individual hospitals collectively as FBOs, and as of now, we feel there has been, it's in the about 6 billion that is still not cleared.
Financial backing for SHA is another contentious issue. Despite government assurances of robust funding, the reality on the ground tells a different story. The allocated budget falls significantly short of what is needed for a smooth transition and operation, leading to service disruptions and increased out-of-pocket expenses for patients, leaving many to question the sustainability of SHA. The scheme is divided into 3 levels: the primary healthcare fund, the critical care fund, and the emergency critical care fund, which were meant to kick in automatically to cushion members who exhausted the primary care fund. All 3 are grossly underfunded. The government allocated $4 billion for primary healthcare out of the $50 billion requested for the fund, which caters for 99% of health seekers. For the emergency and critical care fund, Treasury allocated $2 billion out of the required $75 billion. Stakeholders feel the transition was a bit rushed and the government should have enhanced NHIF to rid it of its perceived shortcomings, or at the very least taken the time to fine-tune all the logistical and technical details first before the rollout.
Give us a 2-year transition and allow Kenyans to register, to be educated. Even allow yourself to develop the portal, to develop a provider payment mechanism. So in our view, if we had taken 2 years from 2023, say October, and said, and given a hard stop as October 2025, we would have had sufficient time to get ready, to prepare, and to do this better.
5 attempted. Definitely.
However, the health CS, Dr. Deborah Barasa, has, however, defended the rollout and operations of SHA, terming it as a silver bullet to Kenya's ailing healthcare system.
We are looking to ensure that we are leaving no one behind. So regarding the challenges that we have been facing, yes, we've been facing a lot of challenges, and we are engaging the community. We are looking at how can we continuously improve the system so that each one of us benefits. Because ultimately we want to build trust, we want to mitigate the resistance in the community and improve the communication and sensitization.
As the debate rages on, SHA's implementation remains a critical test for Kenya's healthcare policy. Stakeholders are calling for immediate reforms, transparency and accountability to salvage what they believe is a transformative step towards universal health coverage, and are of the opinion that failure to address these pressing issues will be the Waterloo for the vision of accessible and equitable healthcare for all Kenyans. Mary Muoki, Citizen TV.